So this is a scenario that one of our instructors about 10 years ago saw in Somalia. So we redid it. He was working very similar to what you're doing, and medic, and one of the security guards comes up and armored truck was hit by an IED, which I don't think happens as much anymore, which caused no injuries and minimal damage. So what's your thinkings so you got the radio report, they're coming in 5 minutes till they get to your clinic. What are you thinking?
So there can still be internal injuries from tertiary blast. So thinking about the shockwave itself, they might not have been hit by frag or thrown or anything like that, but the shockwave can cause blast lung, can cause internal bleeding, hearing damage. You're saying there ataxia and vertigo. So yeah, can be damage to. It could be signs of TBI from that, just from the blast wave itself.
So what are you preparing as they come into your clinic?
If there's more than one, triage area. There's
Just one. Just one.
Or just one coming in. Just an initial assessment. Then we're going CABCD with him, looking for them life-threatening injuries, treating and finding and treating as we go. If we move all the way through CABCD and there's no immediate life-threatening injuries, then we can go into the secondary survey. Yeah.
Okay, let's see what he presents with. This is your CABC and your CPRO. We always get CPRO right off the bat. Read through that and let me know if you see any red flags.
There's no massive red flags straight away. The pulse saying that it's thready could indicate hypotension, but I'd want a proper BP to confirm it. But everything else is within sort of normal ranges, which doesn't mean he's not hurt. It just means he's compensating well, I'd say.
Yeah, all right. So we can look at a couple things. Minor bleeding from the ear, there's going to be your red flag. And pulse rate, I don't know, 92. I put a red flag here. If it's a fit, 18-year-old born national, 92 is high, but it's not crazy red flag. But we can go on to our D&E. So the D, where we have the A in AVPU, alert and oriented times 2. What does that mean?
Yeah, that's worrying. He's alert, but he's only orientated to a person and place. So he's not fully aware of, everything that's happening. He might not necessarily be able to talk you through the incident. He might have lost a bit of time in his day. He might be saying, we're going out on patrol soon, but he's actually just been out and being hit sort of thing. So he's not fully there. But he is alert in the sense that he's maintaining his own airway and he's breathing and things like that. He's not worrying on that side of the AVPU scale, but it is worrying on the side that he's not completely aware of everything.
Good. I think there's some discussion on putting a C after alert, and the C is confused, verbal, pain, and unresponsive. So this would be one of those C's. Yeah, I still like to times 4 because there's 4 layers for me to assess. What is this? What's PERLA?
Pupils equal, around, reactive to light, and accommodating.
So what does that tell you about this casualty?
It tells me that he's scoring well. He is PERLA, so his pupils are equal, round, reactive to light, and accommodating. It doesn't rule anything out, but it doesn't rule anything in at the same time either.
Okay, good. And for environment and expose, no major problems there. And let's get the rest of your CABCDFGH. So we've got a full set of vitals. We're going to document our ATMIST and then go into prolonged field care. But let's look at F first. So here's your CPRO, primary vital signs, B, secondary vital signs, and we have some lab scores. Sorry, these red flags are off of it. So where are our red flags in our CPRO beast?
Yeah, you can put one on pulse. Like my rule would be over 100, but you can put one there. Specify, is that 99% on room air?
Yeah, 99 on room air.
So that's fine. BP's fine. No size rhythm. There's one, I'd put one on the alert state in beast. Sugar's fine. Temp's fine.
Yep.
And pain score, obviously, it's not normal for somebody to be sat 8 out of 10 pain.
Yep. So this flag here is meant to be right at the pain. Yeah. So that's a problem. What can you do for that?
Depends at this point. So without giving an initial diagnosis and a couple of differentials, I'm not going to start throwing pain relief at him just yet until I've gone a bit deeper on my secondary survey, I don't think. Let me have a think. So mechanism of injury is a blast, but he's not been thrown. He's not suffered any primary, secondary injury.
Breathing's fine.
Yeah.
BP is fine, so he's not bleeding out or he's compensating. But he's 8 out of 10, which that's a lot. What are you going to do for that?
I want to know where is this pain? What's
it's ear pain.
So yeah, depending on your local protocols, you can start him on some pain relief. There's no reason. He's ANO2, so would that rule out Penfrox?
Well, you're actually in Somalia at the moment. What drugs do you have?
Yeah, so Penfrox, ketamine, morphine, IVP.
Would you use Penthrox?
No, not for this. Not for a head injury with altered level of conscious. No,
What would you use?
I've gone blank, if I'm honest.
Yep. So ketamine is great, but IM ketamine is super, super, super safe. There's absolutely no way for you to overdose on it. And there is a bit of ketamine problem with raising blood pressure. Is that a problem here?
No.
Now, what about IV morphine? Would you have a go at that?
Yeah, there's no contraindications to it. It's not in respiratory depression. It's not, unless obviously allergies, but no, there's no contraindications to it. So yeah, to be fair, my front line here would be IM morphine.
IM?
Yeah.
All right.
From an autojet.
Okay. How many milligrams?
4. It's 10 milligrams, but 4 specifically because it's a local. So we don't do the protocols here, so that we don't do IV on the locals. So that's why it would be IM for him.
It'd work because he's normotensive. Yeah.
Yeah, he's not hypothermic. He's normotensive. He's not in respiratory depression, so he could have IM morphine.
Okay, I'm all right with that. What can you give with morphine to potentiate the morphine?
I'd consider tying it with an antiemetic.
So I think paracetamol is frequently combined with prescription opioids like codeine, tramadol, oxycodone. So paracetamol is great with like an NSAID because the pain pack, which is a paracetamol and an NSAID, is great for pain of 3 or less, but this is 8. So opioids, I'm happy with that. And if you give him 500 milligrams or a gram of paracetamol, you said IVP. Are you allowed to give him IVP?
Not for a local, no, because we just don't do any.
You can't go into the vein. Okay, so
yeah. I would have oral access to oral as well.
You can give him 1 gram paracetamol, which works from 1 to 3 pain anyway, and then with the IM morphine, they would work together for a bit of a stronger dose. And the other thing I like to do is explain to the person I'm giving this drug to that this drug is amazing drug. This drug is just fantastic. I've been using this for 35 years and I've never not seen it work. It's amazing. And I mean, you have to go through an interpreter, but there's better outcomes from your casualty if you don't lie. You're not lying at all. I've given tons of opioids and they work, but it helps with a bit of the psychological behind that.
Yeah, no, 1,000% I agree with that. I've seen it before, like with the IM auto injectors. If you just get a grip of your casualty and tell them, listen, I'm giving you this, you're going to be fine once this goes in, you'll be all right. As soon as they feel that needle, you get even though we both know it hasn't actually done anything yet, it's gonna, but it hasn't done anything yet in that second, but they're in their head, it does do something, yeah.
Good. All right. So we can work on our ATMOS, get documentation. If you have them for a while, you automatically roll into prolonged field care. But you're in Somalia at the moment. How long would you actually sit on this guy before you turfed him out?
Not long. Definitely as a local. I'd palm him off to SPU, the police unit, and just send him straight to the local hospital.
Yep. So you can get a sampler off the guy?
Right.
Sorry, he's from South Africa. He's not local.
Ah, right. Okay. Yeah, I assumed from the picture on the first slide that they were a local.
I was being cheeky.
Right, okay. Why is he on the antibiotics at the minute? Oh, sorry, it's NSAIDs and anabolic steroids.
Yep, no antibiotics.
Right, so that's just for vanity. He's juicing, and right, okay. Probably.
So what's a red flag here?
Concussion 2 years ago, Ukraine.
Why is this a red flag?
Repeat CTE and indicators for TBI.
Yeah, well done. Good. So this is a huge red flag for us. So quick review of the systems. Well, we'll just worry about neuro because the rest of these systems we're not too concerned about. We have ataxia, which is a red flag, which we already knew. So now we're down to D in our CABCD. D is for drugs. We gave drugs, 2 drugs, right? We give 3 drugs. We give paracetamol, IM, opioid, and then you gave an antiemetic. What antiemetic do you give with your opioids?
Ondansetron.
Fair enough. 8 mils. Yeah.
Yeah.
Cool. So we have D, differential diagnosis, we have D, diagnostic tests, and we have D, drugs. All of those are CABCD, the D part of it. And we have a rough differential diagnosis. Which one of these would you like to do a diagnostic test on to nail down your idea?
Well, me personally here, all I can do is have a quick look in his ear.
There we go. Yep. So you can do a diagnostic test with your otoscope. Good. What else?
Everything else is going to need an MRI. Yeah, I can't see a
What about this one here?
subdural image. Oh, right. Sorry. Yeah, ICP. Can lactate? No.
No. So you haven't taken APIS yet, have you?
No, I haven't. No.
So in your APIS course, austere and pre-hospital ultrasound, we teach you how to measure your ICP looking at the diameter of your cranial nerve 2, your optic nerve sheath. So you get an ultrasound probe, you get a whole bunch of gel on the eye, you put the ultrasound on the eye, and you can see through the eye, cut back all the way down to your cranial nerve 2. And what's interesting is the fluid around your second cranial nerve is exactly the same central nervous system buffer that goes to your head all the way down to L2, where your cauda equina, where your spinal cord kind of ends. All of that is the same pressure. So we can make, this is why we do spinal tap. Well, docs, I've helped tons and tons of that in the emergency department doing spinal taps, and you can measure your ICP. Well, now we can look at the back of the eye and measure the ICP as well, because it's the same fluid. It just flows from your eye to your head all the way down to L2. And we'll teach you that during that APIS course.
There we go. I look forward to that next month.
So, and then during your TTEMS, you're going to learn how to do otoscope and ophthalmoscope, and then ultrasound. The rest of these, you're right, we have to kind of look at CT scans, which we haven't had, but good. So we can do some testings. You can use a 128 hertz tuning fork it's called the Rene's test and Weber's test. And you hit the tuning fork and you put it on the top of their head, and then you hold it up here by the ear. You top of the head until the sound goes, and you hear it over here to see right next to your ear to see if you can still hear it. You can do a halo test. What is a halo test?
It's looking for CSF.
Good. There could be some glucose, but there's normal glucose in the blood. So yeah, just look for a little bit of halo on the outside of that. Yeah. Here is the back of your eye. This is cranial nerve 2, which ends right here. You can see where it almost touches your eye. So we measure from the back of the eye, 0.3 centimeters down, 3 mils down. And from here, we're looking at one side of the optic nerve sheath to the other side of the optic nerve sheath. And how wide is that? A normal optic nerve sheath is 5 mils or less. Now, you'll trend this. If it's 3.7 and 10 minutes later, 20 minutes later, it's 3.9, then 4.5. It's all lower than 5, but man, you have a major red flag there. But anything over 5 is a major pathology. So we're measuring this cranial nerve 2. During the TTEMS, we'll teach you I will teach you, I will be there. I'll teach you the otoscope, and we use the arc light to look. We're going to give you an arc light you already have one. Yeah. So we're looking for the cone of light here. And the cone of light means that this is intact. If you don't see the cone of light, that means there's some sort of compromise in this tympanic membrane. And then this is a compromised tympanic membrane. You can see a hole here. So if this guy has a ruptured tympanic membrane, you'll see that here. And you'll take a photo of it with your smartphone, and you can send that along with his records. Or you can telemed as well. Yeah. So we'll get into that. And of course, in the TTEMS, we're going to look at swelling here for any type of otitis media or any type of ear problems. So in your field guide on the yellow section, you have a neurological exam. Did you guys do that in 104?
Yeah, we touched on it. We didn't get a chance for everybody to do one individually, but yes.
Yeah. Okay. So TTEMS, we're going to hit this pretty hard. We'll go through our checklist on a neural exam to see what pathologies, and you do a full cranial nerve exam, and you just document this. I mean, there's not much we can do as paramedics, but we can document and trend. Good. So we have we've got a differential diagnosis. We have diagnostic tests that we've ordered. We've given drugs. But now let's nail down, using the test results, which one of these differential diagnoses do you have?
Well, we've got visual confirmation or a tympanic membrane perforation.
So at this time, we have this. Anything else? Because you can have more than one.
Yeah, it doesn't rule out anything else. That can be on top of any of the others as well. So obviously, like if after I'm trained on ultrasound, if you go over that 5.7 mil, you can, or trending upwards in growing, you can say that query increased ICP, and then all the others are query as well until they've been ruled out by imaging.
Good. So we have a confirmed one. Your tympanic membrane was ruptured. We saw that, but we haven't seen these. Doesn't mean they're not there. You're absolutely right. This is a rule in, not a rule out. Good. So, and we could possibly have one of these. We've got to be careful. So, TBI, this didn't show up. Interesting. So when I converted this into Google Slides. So in your field guide, you did have a list of red flags for neuro, and you definitely want to go through these. Any of these red flags, they are going to get evacs pretty quickly. So spontaneous venous pulsations. In TTEMS, we're going to spend a lot of time looking in the back of the eye, and we're going to get used to some of these veins and arteries so this is the macula densa. So that's this optic nerve, that's the macula densa. And so we're going to look at one of these. We can see the pulsating artery, but if we see another vein that's pulsating, that indicates ICP as well. But we've got an ultrasound that's going to give us a much better option. But we can look at SVPs as a differential diagnosis. But we'll focus just one extra thing that we'll talk about in the TTEMS. So treatment of TBI. Why do we elevate the head of the bed?
It's gravity. If you're making it harder for the fluid to get up there, there's less fluid going to get up there.
Good. It'll help drain that excess pressure. Going to keep the neck midline. We want to have our SVP consistently at 110 if possible. If we have ETCO2, do you have one in Somalia?
No.
So if you did have one, I would put that on a blow-by just to make sure that my ETCO2 is in the range that I need. We want a core temperature that doesn't get too high. Going to prevent seizures. How do we prevent seizures?
Prevent seizures. I'll minimize any external triggers, like heat, cold, light, excessive movement. Like we can just minimize any of them external triggers.
Good. Now, what about hypersaline? Do you carry hypersaline?
No, we don't have any.
Okay, fair enough. And that's a stopgap, if anything, anyway. So there's some of the drugs for the pain. You decided on morphine, which is fine. And we get all of this from the CPGs. Do you read the CPGs?
Can't say that I do now.
So if you just search for JTS CPGs, there's 107 or 8 of them, and they are the cutting edge of austere medicine. They're all military, but cutting edge of austere medicine. We'll talk a lot about them in the eye care. So we talked about tympanic membrane perforation. So this is the cone of light. You won't be able to see that anymore. There's a big hole here, which then your bacteria is going to get in there. There's nothing protecting your inner ear anymore. So it's very high risk. So you need to make sure you keep this thing covered. And treatment, you can use antibiotic drops. And this is the nice thing about being an offshore medic, that we can always send that picture to the doc and say, hey, this is what I think I'm going to do. What do you think? Okay, you agree. And then you can give treatment. Good. Yeah. And if you're in a prolonged field care environment, which you're not in Somalia, let's make sure that keeps the head of the bed elevated even whilst they're sleeping, and watch for signs of infection. I'd be looking in that ear morning and night every 12 hours, making sure there's no infection. Good. Any questions?
No, not really, no. Interesting. I enjoyed that one.
Cool.